Rituximab or Cyclosporine in the treatment of membranous nephropathy. Definition: Membranous nephropathy is the leading cause of nephrotic syndrome in white adults. Spontaneous remission occurs in approximately 30% of affected patients, and among patients who continue to have nephrotic syndrome, end-stage renal disease develops in 40 to 50 over a period of 10 years. Applications on medicine. B cells anomalies play a role in the pathogenesis of membranous nephropathy. B cell depletion with rituximab may therefore be non-inferior to treatment with cyclosporine for inducing and maintaining a complete or partial remission of proteinuria in patients with this condition.
GN is the abbreviation for glomerulonephritis. It's a long word, but in essence, these are the group of diseases which affect the kidney. GN is a condition which affects the filters in the kidney, and these filters can either get inflamed acutely, and in that case, it starts spilling the blood and the protein in the urine, or there is a slow process in which the kidney filters can get scarred and the waste products cannot get out of the body, and they start accumulating in the body and have negative health effects. The symptoms which make someone seek medical attention is generally swelling of the legs, sudden weight gain, patients noticing foaming of the urine, that the urine is very bubbly. That is indication that there is protein. Blood pressure suddenly spiking up, having a new rash with having the bubbly or this foamy urine. Those will be some of the symptoms which someone immediately contact the healthcare provider to see if they are developing inflammation in the kidney or glomerulonephritis. The GN clinic at Mayo Clinic is a multidisciplinary clinic of nephrologists who are the kidney specialists, the nephropathologists who are the pathologists specializing in kidney disorders, radiologists. We have the help from the nutritionist and the immune system doctors, the rheumatologists. So when a patient is referred to us or patient calls us with the symptoms which look like they may have GN, they are immediately seen by the nephrologist. The patient is evaluated to see if we can determine the cause of GN by the blood and the urine test, or whether someone needs a kidney biopsy. Then the biopsy is done promptly so we can get to the diagnosis and the cause for glomerulonephritis, and then tailor the treatment specific for that patient. Sometimes we are able to offer certain research trials, which are the cutting edge treatment for the patients with glomerulonephritis.
Pros and cons. Initial therapy for patients with membranous nephropathy is supportive. Immunosuppressive therapy is recommended for patients with persistent nephrotic syndrome. A regimen of alternating glucocorticoids and cyclosporine is effective in 60 to 70% of patients, but has been associated with clinically significant toxic effects, including hyperglycemia, myelosuppression, infections, infertility, and cancer. Calcineurin inhibitors, including cyclosporine, are effective and are the preferred treatment. However, these agents are associated with a high incidence of relapse after discontinuation and with frequent side effects, including hypertension and nephrotic effects.
Here is a disease which we may not be able to totally show just on light microscopy, and it's usually diagnosed much better by electron microscopy, but nevertheless, let's look at it a little bit. This is a kidney. Here's a blow-up of a glomerulus underneath. In this case, this glomerulus, in fact the whole tissue was stained with PAS. The tissue on top is a regular H&E stain. You can see some small glomeruli out here. You can see a whole bunch of tubules. And you don't see too much by way of diseases within the tubules. In fact, in all honesty, if all you had was a light microscope and an H&E stain, you might not think there was much going on in these glomeruli either. However, when you do a special PAS stain, periodic acid shift stain, PAS, in this disease you can see deposits of immune material in the basement membrane, which causes the basement membranes excuse me, to appear quite thick. And if you were lucky enough to have access to electron microscopy, excuse me again, you will notice that the thickenings in the basement membrane are somewhat spiked. You cannot appreciate it just from this PAS stain, however.
Issue applied in Ecuador. Currently, there is no updated statistical information in the country about this topic.
Hi, we're interested in determining the risk factors that are associated with rejection, acute rejection in patients with primary glomerular diseases. And after transplantation, all of our patients needed to have biopsy-proven disease recurrence. We examined the 4 most common types of glomerular diseases, being membranous glomerulonephritis, IgA nephropathy, FSGS, and PGN. This is a large database study, probably one of the largest that's been published or examined so far at a single center. And the interesting finding we had was that out of the 4 kinds of primary glomerulonephritides, the most common one associated with acute rejection post-transplant was membranous glomerulonephritis. And we looked at risk factors for acute rejection in membranous glomerulonephritis, and it turned out that delayed graft function here in a bivariate and multivariate analysis was a significant risk factor associated with 2.3 times greater risk of rejection, whereas induction with Rituximab was protective in bivariate analysis. So what are the significance? What is the significance of these studies? It's important to realize that patients with membranous glomerulonephritis are at an increased risk of acute rejection, and it is important to determine the risk factors so that hopefully we can prevent that. We don't know the pathogenesis of this yet. We are examining some of these questions by looking at antibodies against the phospholipase A2 and try to predict rejection now. That would be important. Other than that, I think that it is important to know that the other types of glomerular diseases are not a significant risk for antibody-mediated or acute cellular rejection. And finally, the major limiting factor for this is that we don't have C4D staining in these biopsies because they go back in time and we don't know what type of rejection this was specifically at this stage, whether this was antibody-mediated rejection or cellular rejection.
Conclusion. Rituximab was non-inferior to cyclosporine in inducing complete or partial remission of proteinuria at 12 months and was superior in maintaining proteinuria remission up to 24 months.